and I'm the current clinical director of the Northwest Genomic Medicine Service Alliance. And some of you I recognise as very familiar faces that we've been working together over the last number of months and longer, and delighted to be joined by colleagues potentially interested in working with us on this programme of work in pharmacogenetics. So I'm very briefly just going to say a couple of words and then introduce John. But as you can imagine, this is a team effort, and one of the things that has really been helpful to us over the last year and beyond as we've been progressing this work has been to involve health professionals with a whole range of different skills. So Jess leading our pharmacy team up in the Northwest, Vidya working in health informatics, John, who's a clinical fellow in genetics. We've got lots of people helping us on the health economic side, implementation science side, and then in the laboratory. And so the only way that we can really make this work is by us all bringing our individual skills to the programme. And we've been very lucky to work with colleagues in primary care in the Northwest who have guided some of our thinking about what we should be doing. This project is funded by the NHS through its transformational programme within the Genomic Medicine Service Alliance. The past year has been funded as a project based in the Northwest, and we're looking to then expand that over different regions across the country. We have taken advice from GPs about which drugs they think are the most important to be focusing on, and how we get the information from our laboratory that is relevant to help safe and effective prescribing, and talking through some of the logistics of where we're at. So hopefully today we can give you a little bit of a background as to what we've done, where we're up to, and what the next steps are. And then we're very keen to hear from you for any questions that you may have that we can either answer today or take away and follow up with you. So hopefully that's given you a little bit of a feel for what we're doing. And I'm going to hand over to John just to talk through the specifics of the project.
Perfect. Thanks, Bill. Now, before I start talking, I just want to check people can actually see my screen. Anthony or Vidya, anyone can tell me?
Yeah, all good, John.
Yeah, I can see it, John.
Excellent. Perfect. Thanks very much. So the Progress programme is exploring how we can implement pharmacogenetics in clinical practice. It's an area that our group have been interested in for some time. And over the past few decades, there's been extensive evidence built up around how you can use genetic data to inform the prescription of many common medicines. But around the world, and certainly in the NHS, there's been a lack of implementation. There's a number of reasons for that, which we'll touch upon. But one of the huge challenges is about finding ways to get that data into the hands of clinicians who are going to be using that information in a readily interpretable format and an interpretable time frame. And so I'm going to go through what we've been doing to address this and how it will hopefully culminate in the Progress trial. So a little bit of background. Poor medicine's effectiveness and adverse drug reactions are common and costly phenomena. They're related to a number of factors, including poor medicine's adherence, suboptimal dosing strategies, but common genetic variation also plays a role, the concept known as pharmacogenetics. Many medicines need to be activated by enzymes in the body before they can have their desired effect, but common genetic variation, which is present in the vast majority of us, can influence the activity of some of these enzymes. And large biobank studies have demonstrated that pretty much all of us will carry a genetic change that would influence our response to a medicine. Now, if you have a reduced enzyme activity, it can reduce the levels of the active metabolite of that medicine and so reduce its effectiveness. Now, despite extensive evidence for multiple gene drug pairs, there remains a translational gap. There's 26 gene drug pairs with explicit pharmacogenetic prescribing guidelines, as per the Clinical Pharmacogenetics Implementation Consortium, which you can think of like the NICE guidance for pharmacogenetics, or the Dutch Working Group, which are the kind of European equivalent. Now, despite that evidence, only 4 of those gene drug pairs have reached clinical practice in the United Kingdom, and all of those are tested for in what we call a reactive testing strategy, whereby a patient might present to a specialist clinic. You would consent them for a genetic test, send the blood sample off, get the result back weeks or months later, and then use that to inform prescription. That's the kind of traditional model. And it's recognized that that is not going to be the model that delivers pharmacogenetic testing at scale if that's to happen. So genetic variants which influence response to medicines are common in the population, as we've touched upon. And this is what we've been really good at in the past. This is what kind of clinical genetics spends a lot of our time doing, establishing genotype to phenotype relationship, how genetic changes influence our response to medicines, or how genetic changes can cause rare disease. What we've not been quite as good at is developing technological solutions to actually leverage that information and then implementing it in clinical practice, putting it into practice and understanding how it can integrate with normal practice. And so that's what we really need to do. And alongside that, we need to understand PPI acceptability. So are patients happy with us doing this? Are they happy with the way we're proposing storing their data? And then accompanying health economic analysis. Who should we be targeting this testing towards? And so, as I say, this is what we've been very good at. Our group and this program of work is focused very much on the right side of this spectrum. So actually implementing these gene drug relationships in practice to recognise the benefits of pharmacogenetics. And that's what the Progress programme, funded by NHS England, as Bill's mentioned, is really around. So the Progress programme over the past year has been split across 3 core work packages, which I'm going to touch upon. Work package 1 is around basically developing the genetic test. So in our laboratory, developing and identifying genomic technology that can be used to test for these genetic changes of interest. Work package 2 is around developing an informatics support solution to actually support that pharmacogenetic guided prescribing, and the kind of critical importance of that I'll come to. And then work package 3, which is what we're here to talk about today, is implementation in general practice as part of the Progress trial. And as I alluded to before, we've been working with health economists, implementation scientists, and public stakeholders to develop this program of work. So very briefly, with regard to work package 1, we scoped the available systems that could undertake pharmacogenetics that were available on the market and validated them via our laboratory team here at the Northwest Genomic Laboratory Hub. We identified the kind of standard performance statistics around sensitivity, specificity, but what we recognised was particularly important were things like turnaround time, cost, and throughput, because pharmacogenetic testing, compared to other types of genetic testing, you're talking about relatively high throughput and low complexity, whereas traditional genetic testing is high complexity but relatively low throughput. So it's changing that paradigm ever so slightly. And so we reached upon a system which is being used for the Progress programme. It doesn't mean this is going to be the solution used across the NHS, but the Agena Veridose core system and another system to look for copy number variation. Critically, you'll be interested, the turnaround time is a day, so much quicker than standard genetic testing, and the cost is cheap. We're talking £20 per sample. So this isn't the kind of traditional genetic testing that we've spoken about for many decades, which is very expensive and takes a long time. It's very quick and hopefully relatively cheap. So with regard to informatics solution, why is this important? So let's give you a clinical scenario. A patient presenting somewhere in the healthcare system requiring a prescription of clopidogrel. We know that variants in CYP2C19, one of the P450 cytochrome enzymes, can impact the activity of clopidogrel. And so this is what the raw data looks like coming out of our lab system, the Agena system I showed you before. But that means absolutely nothing to the vast majority of clinicians, quite understandably. And so we need a process to move that through into something that's meaningful to clinicians. So having this on your genetic report means that you should be prescribed an alternative antiplatelet. So we've developed a piece of software that can do that automatically. It cuts down enormously on the bioinformatic time required to interpret these data. So again, we're trying to speed up that turnaround time to get the results back to you guys as quickly as possible. But the real challenge, and we're kind of getting close to talking about implementation, is that's fine. These data sit inside our laboratory. We can put them into any format that we need. But ultimately, we're not going to be the ones using this information. It's going to be you guys in the community in different parts of the healthcare system using disparate electronic healthcare record systems. So how do we get that information out from our laboratory into a format that can be used by you and your colleagues? So what we've done is developed a solution in the first instance called Geno. It's a standalone clinical interface that you can interact with to view this data. Now, this will be stored as part of an open data standard, which means that hopefully going forward, it will provide some interoperability. But during phase 1 of the Progress program, so when you and your colleagues, if you're interested, begin to use this, it will be as an external interface that I'll show you in just 1 second. But ultimately, that's not what we want to do. We recognize that we want to create as minimal disruption as possible, ideally no disruption, to your prescribing workflow. You're busy enough without having to think about pharmacogenetics and the interpretation therein. And so we're launching quite a large piece of work over the next few weeks to develop a structure that will allow us to push that prescribing data back out. So when you're using your electronic healthcare record, whether that be EMIS, Epic, or System 1, when you go to prescribe a medicine, if that patient has pharmacogenetic data available, you will get a pop-up giving you advice, or you will get inline notification, and we'll be developing that alongside clinical stakeholders to ideally mean that you're not having to go out to a separate system. And we're working with different clinical decision support companies to integrate that within their core structure at the moment. So I'll very briefly show you, hopefully this will work. I'll show you what the Geno platform looks like at the moment. So you can kind of see what people will be using and what this type of data looks like. So bear with me just 1 second while I bring this up. And we will have lots of time for questions at the end as well. So I definitely will come back to anyone. So I'm hoping that you can see this okay again. So this is the Geno system. So I want you to imagine that as part of the Progress study, a patient has been recruited requiring a prescription of simvastatin, for example. And the examples I'm giving here and the patients I'm giving here are all fake. They've just been inputted to test the system so you can see what it looks like aesthetically. But everyone will have a secure login. This is hosted by the Manchester Foundation Trust. All the IG processes are in place, and there's been a number of data protection impact assessments performed. It's linked to the NHS Spine. So this is a test site at the moment. So again, nothing you'll be seeing is real, but in reality, any patients that you had that enrolled in this study, their data could be uploaded on here, and we could link that to their pharmacogenetic data. So you've received a notification saying your patient data is available. This is a test patient, and then here you go. So the patient has been enrolled in the Progress study because they were prescribed simvastatin. Prescribing recommendations can be reviewed below. This patient has not particularly kind of interesting pharmacogenetic results. It shows that they're a normal function for simvastatin, and you can initiate therapy with a recommended starting dose. You can then search for a number of different medicines and get different guidance based on those results. The idea and what we're hoping to do in that first phase is present these guidance and this information in a way that creates as minimal disruption as possible and is as clear as possible. We don't want to go down the route of what often happens with pharmacogenetic studies, where the end users having to think a huge amount about the genetic data and the nuance of the interpretation. We want to give clear, concise guidance that have been co-developed by international bodies such as CPIC, ourselves, and clinical pharmacologists. So in the first part of the study, this is what anyone who is recruiting patients to would initially see. Now I'll go back to my presentation, but as I say, eventually our ambition would be to push this directly into your EHR. So implementation, what does this look like? What is the Progress trial? So in the first instance, we want to make sure this is right, and we're not kind of disrupting things enormously before we expand our recruitment geography across England. So we're giving the system, the prescribing system, to 5 general practices across the northwest of England: Greater Manchester, Liverpool, and Cheshire. We've written a protocol, which I'm going to go through in just one second, where patients are recruited to the study after prescription of an SSRI, a tricyclic antidepressant, a statin, or a PPI. So that would be the trigger for recruitment. We would then aim to have a turnaround time of testing of 7 days, and then upload these data in phase 1 to the Geno platform or back in to the electronic healthcare record. Everything is undertaken via research ethics. So we are we have kind of full consent from patients to extract data from the primary care record, so we can understand more about both utility outcomes. So how are we able to return the data? How is it being used? But also, what is the impact on patients? And so doing it under research ethics provides that flexibility and that framework, because at the moment, there is no real UK guidance for pharmacogenetics. So we thought that that was particularly important. Now, phase 2, which is what we're kind of touching on here, our commitment is that we will be expanding our recruitment geography, and we will have at least 1 recruiting centre from each of the 7 GMSA regions in England. We'll be looking more at patient-focused outcomes for clinical utility, so using things like secure data environments to look at longitudinal outcomes and how having these data impacts on GP attendance, hospital attendance, rates of ADRs. And then we'll be looking at integration with other EHR providers. So at the moment, our focus has been on EMIS, simply because of the partners we have at the present, but we are committed to making sure we can integrate within Epic and System 1, and we already have those relationships being developed at present. And eventually, after the Progress programme, which is an 18-month trial with scope for extension, the idea is that we would look that this would develop into a clinical service. Certainly a lot of the processes that we've learned along the way would inform the design and development of a clinical service. The reason that we want to focus on GP and primary care is because we realise this is where the vast majority of prescribing happens. It would be somewhat straightforward for us to try and do this at our hospital here, where we already have a large genetics lab and we have an Epic platform, but just doing it at one site does not answer the needs of the NHS, where people move around the healthcare system and move around different healthcare facilities. So I don't want to go over this in too much detail, because I recognise I've just introduced an awful lot of information there, and I was going to kind of zoom into how recruitment would work. I might do this over 5 minutes, then I'll take a quick pause. So we have put a lot of thought into how we can endeavour to make sure that recruitment to this study is as minimally disruptive as possible. It's impossible to completely reduce that disruption, but we recognise that you're incredibly busy as it is, and so we don't want this to become another significant burden. So we've introduced parallel recruitment approaches. So there's face-to-face and remote recruitment models. You can either issue the prescription if you think there's a clinical need at the time of presentation, or you can delay that and then use the data, which I'll come to in a second, to inform the eventual prescription. The study is on the CRN portfolio, and so we'll have recruitment before support from the clinical research team. So let's say a patient, you see them either face-to-face or virtual, and they say, yeah, I'm interested in taking part. They will be provided with a PIL, either physically or electronically. And then if they wanted a remote recruitment model, there's a number of options for how this would work in practice. But the idea is that they would be given a recruitment pack from the GP, which included saliva sampling, a saliva sample. They'd be contacted by a research nurse practitioner who would be able to consent them virtually. So again, we're hopefully not taking up huge resources from the actual primary care setting itself. They complete the informed consent form via the telephone, complete all the REDCap recruitment proformas, and then the patient will return their saliva sample, which the research nurse had supported them through, to the GP. That would be then sent via normal internal clinical samples to the genomic laboratory hub. The face-to-face recruitment model is kind of a bit more straightforward. It's your kind of traditional recruitment approach, which would be that the patient was given an appointment for a CRN research nurse clinic. as soon as possible, and we'd ideally aim that to be within 1 to 2 working days. And we take an EDTA blood sample. So we have this parallel pathway, face-to-face remote consenting model, but also we can do this via blood or saliva. We just want to try and build in as much flexibility as possible. And then the pathways converge. We have a testing approach that's currently based in our lab, and we explore how we need to adopt that for different regions around England. But the idea is that once the results are available, exported as a CSV file, I've kind of shown you what the informatics solution looks like already. So that would be uploaded into our system. If it was phase 1, that would be via Geno. If it was phase 2, that would also be direct into your EHR record. You'd receive a notification telling you the results are available, and then there's pathways for what you can do. So if the prescription has not already been dispensed, then if a dose adjustment is indicated, there'd be a mechanism for contacting the patient to reissue that prescription. And if it wasn't indicated, then there'd also be an approach, but it could be via an electronic message. And then similarly, if the prescription was already dispensed, again, we would have a route for recontacting the patient and then recording what that decision was in the records. And one thing that we recognise is that in any pharmacogenetic service, if you look, we spent a lot of time talking to colleagues who are delivering services like this on a day-to-day basis around the world, and specifically in the US, and pharmacists play an absolutely critical role. And we're very fortunate to have a GMSA pharmacist on the call. A number of GMSA pharmacists will be on the call, but our Northwest GMSA lead pharmacist is Jessica Keane, who might want to come in just to talk a little bit about the role of the pharmacist. Jess, do you want to come in?
Hi, yeah, sure. I think what we've learned from speaking to the practices in the Northwest already that are going to be piloting the pathway is that much like with the recruitment model, the roles will vary based on the pharmacy support that's available within the PCNs. We know that some pharmacists are interested in referring patients in for recruitment, but primarily we see the role kind of at this section, whereby when the results have come back, they'll be advising around reviewing the results and considering the alternatives where patients do have guidance appear that suggests that they should be considering an alternative, because obviously that alternative will also be impacted by the patient's wider clinical condition, their other comorbidities and other medicines. So that's the main role for pharmacists that we see within this particular project. And then again, importantly, the communication with patients, I think particularly where their results indicate that a change to the prescription is needed, so that we can explain to patients why the prescription will be different. And it might be something very simple that just says your genetic results indicate that this medicine is less likely to be effective for you, but that just to be able to have that kind of counselling approach with patients who may have some more questions. The other thing to say is that SPS, the specialist pharmacy service who provide the medicines information, are on board with their project, and they will also be supporting for some of the more complex queries. And that's not to do with where the pharmacogenetics is complex, but more so where there may be a lack of other alternatives, because pharmacogenetics suggests that, you know, the first choice is not suitable, but perhaps the second choice is not suitable for the patient for another reason, and it becomes a more complex query. We think that those types of questions will be fairly minimal, but we thought it's prudent at this point bringing that support from the medicines information specialist, so they'll be working closely with us and reporting to us around the types of queries that they're getting, the numbers of queries that they're getting. And clearly, if there are a number of queries that are coming back because of pharmacogenetic results from these patients, then something is not quite right in terms of how the guidance is being presented, and that's something that we'll be able to iterate as we go through the project. I think that's everything from me, John.
Thanks very much, Jess. That's really useful. And kind of just to stress that we are kind of committed to ensuring that pharmacists are as engaged as possible with this programme of work. Pharmacogenetics just will not be delivered in the NHS or in any healthcare system without the engagement of pharmacists. So it's absolutely key. So any of your practices, if there are pharmacists you think would be particularly interested in this, I'm sure that we definitely would. And I know Jess would be very keen to speak with them. So just moving forward, I'm not going to go into this in too much detail. So we're moving into year 2 of our progress program, and so we're expanding on our work. We're, as I've said, looking at how we deliver this across different electronic healthcare providers, and some of that is around developing a pharmacogenetic clinical data repository. We're looking at how we can provide patients access to their data, so developing tools so they can interact with their information, and holding user focus groups to understand how they want to perceive to engage with that. We have, again, a large portion of health economic work that will be working alongside the progress program to understand where this delivers value and who it best delivers value to. So I'm going to leave it there. I think the progress program itself is a kind of very large project, so trying to summarize it all in 10 or 15 minutes, I may have missed out things that you think require clarity. I'd be more than happy to take any questions. Just with regard to timelines, we're hoping to launch the progress trial here in the Northwest towards the end of April is our ambition. There'd be a kind of 6-month embedding period, and then our ambition would be to look at expanding our recruitment geography towards the beginning of next year. So we'd like to really begin engagement with sites as soon as possible once we get recruitment started in the Northwest of England. Before we open up for any questions, Bill, is there anything you wanted to add?
No, I think firstly, it's just really great that you've expressed that interest. You know, it's really important that for any project to be successful, that we have early adopters, people who are interested in the science and really seeing how this can benefit patients. And hopefully by the time that your surgeries are potentially brought on board, we'll have ironed out a few of the wrinkles that will certainly emerge over the coming months.
Perfect, thank you. Any thoughts or any questions from anyone? We'll make sure that you have all our email addresses if you want to ask anything in more detail at any stage. But yeah, we'd be happy to hear any feedback as well. Please do feel free to raise any concerns. Marit.
Yeah, just wondering, how are you planning to allow the patient access to the data? Are you thinking of NHS app, or what are your thoughts?
Yeah, so that's something that I think in an ideal world, you'd love to do that via the NHS app. And Munir Pir-Mohamed, who's one of the leaders in this space from a clinical pharmacology perspective, has definitely spoken about that before. It'd be a really good use case for it. I think there's obviously challenges around, because there's lots of demands on that service about getting that to the top of the priority list to include it. In being pragmatic within the progress program, we will be looking at 2 modalities. The first is incredibly simple, which is how do we structure a letter to return that information? But that's definitely not the best route, because it's a letter, it's a PDF that disappears. We'll be looking at how we can store that as structured data that will be taken from our clinical data repository and then potentially moved into a platform that patients can interact with. So like the Geno platform, but a kind of a more user patient friendly version of that. But we'll be hosting a series of engagement workshops, and we're working with the health informatics team at the University of Manchester to basically put on program work to understand what patients need around the delivery of that data. Malaf.
Hi. Yeah, I'm a GP. I'm not from Manchester. I'm actually from Huntingdon, but I've been invited here. So thank you for that. Just to say that, so we did something like this about a year or so ago. Because one of my previous salaried GPs that went into research at the MRC here in Cambridge, and it's brilliant, actually. I mean, unfortunately, we couldn't get an NHS provider to do the samples, so you went off to Germany, but we got a result within a week, and we were doing it on antidepressants. But the report we'd get as a PDF, and they'd give us sort of red, amber, green, so that you can prescribe this type of drug or not, and that was pretty straightforward. So that's how it was integrated. It was PDF. Then we put it as an active problem on the weariness on the thing saying, yeah, these are the antidepressants or you can give. So that was good. And what we did was because Alina, the researcher, the GP, she actually did all the recruiting and everything. So I realized that we can't be recruited for till next year according to your timeline. But just to give you the feedback, yeah, it does work, and it's actually pretty straightforward in primary care. If you've got the will there, it's pretty straightforward. Thank you.
Fantastic. That's really good to hear. And we know that certainly a lot of sites around Europe, certainly in the Netherlands especially, are delivering pharmacogenetics routinely. One of the challenges and the reason we're really keen to get that informatic piece down is this data is, as you'll know, will be relevant to a patient throughout their lives for a number of different prescribing events. So a patient presenting requiring antidepressants, obviously that data might be relevant at that moment of time, but it then might be relevant 10, 15 years later if they need antiplatelet, for example. And what we found, and what centers around the world has found, is that if you store that and structure it as a PDF that's not queryable or searchable in any way, that second time that you need the data, people either don't know it's there or can't find it or can't access it. But that's really great to know. Yeah, great to have you on board.
Thank you, Martha.
Any other thoughts or questions at all?
One of the things that we know is that you will all have different ways of working within your practices. There'll be some commonality, but there'll be different things, different processes, things that you do, different resources available to you in terms of practice pharmacists, nurses, in previous involvement in research. And so we'll be very keen to have those individual sort of bespoke conversations with you about how, we deliver the right support to you, what systems that you have in place, for when you're seeing your patients, though they'll be different. In the Northwest, predominantly, we use EMIS, but that may be different in other parts of the country, and we need to know that we have that sort of functionality, covered across the country. And then also the support from your local CRNs may be slightly different. Some may want to get engaged in the project, others less so, and how much ownership of the project you want to have within your surgeries with the recruitment, as opposed to getting support outside, and how we can provide that support to you, be it on a per patient fee element, or supporting time for a research nurse, or engaging with the CRN team.
Yeah. Wonderful. So if no one has any more questions, what we'll do after this meeting is send up a follow-up email. The recording will be on there if you want to watch any bits again. Our emails will be on there if you have any questions, and we'll also try to outline what we perceive to be the timeline for expansion of the Progress programme to other regions, because next year will come around very quickly, and also how we will then begin that more detailed engagement with potential partner sites, and how we'll also link in the different GMSA regions. So there will be some coordination from each GMSA site, and then who will coordinate with us, but we'll put all that in the email. So thank you very much for attending. It's been really nice to have the opportunity to see so many people who are engaged. So thank you, and hopefully we'll have the chance to work together very soon.
Yes, don't hesitate to contact us as you're going away and mulling over the interesting things we've said.
Thank you, everybody. See you soon.
Take care. All the best. Thank you. Appreciate it.